Okay, recording should be going. Get the slides up. Okay. So some of the questions that you're going to see tonight, of course, I wrote, but then I also pulled a lot of questions from USMLE RX, like their question bank, and then BRS Pharmacology. So the ones from USMLE RX, if they seem, well, first of all, I only pulled the ones that I felt like you guys were ready for because a lot of them integrate like a lot of pathology and lab values. But still, like if they seem really difficult, like don't freak out, don't panic. They are much harder than anything you're going to see tomorrow. So, but they still should be helpful. Okay. So I have not covered the last two lectures yet. So I'm going to go very quickly through the material so we can get to the questions. Okay. So treating TB is something that is very high yield. You're going to get asked about a lot. So we have two options, either RIPE or RISE therapy. Can someone tell me when you would choose RISE over RIPE? Like what kind of scenario would you prefer, or would you choose RISE therapy over RIPE therapy? Any ideas? You guys are always welcome to unmute too. I don't mind that at all. Right, liver disease. So yes, that's exactly correct. So if you have a patient who presents with a lot of liver problems, go ahead and use streptomycin because it's nephrotoxic instead of hepatotoxic. Of course, the other three, rifampin, isoniazid, and ethambutol, they're all hepatotoxic, but it's better to have three hepatotoxic. It's better to have three hepatotoxic agents instead of four. I think that's kind of the logic there. With rifampin, the thing you're going to see most often is that it carries an adverse effect where it has the ability to stain bodily fluids red or orange. So of course, if you don't like alert the patient to that, that can be very alarming. So that's an important side effect you want to watch out for. And then also isoniazid. Isoniazid can cause peripheral neuropathy. So you want to supplement with a vitamin B6. And then also, it's one of the drugs that is metabolized by N-acetylation and can lead to a lupus-like syndrome. So do you guys remember the mnemonic for your N-acetylators? Right, SHIP. And somebody go ahead and type out what does that stand for. And I'll keep talking while you do that. All right, the last one is ethambutol. So the way you, I would suggest remembering its adverse effect is when you think of ethambutol, think I-thambutol. So EYE thambutol. And that will hopefully trigger your memory that you're looking for optic neuritis. Okay. So I threw in a few, yeah, you guys got that SHIP mnemonic right. So make sure you know that for tomorrow. I threw in a few first aid slides. I just tried to circle the things that are most important for you right now. So ethambutol with the optic neuropathy, and you can call it ithambutol to help you remember. And then isoniazid, one thing I'm not sure she really talked about, but it's very high yield. It's the only TB agent that can be used as solo prophylaxis against TB. So it can be used by itself as prophylaxis for TB. So that's very important. Okay. Um, Metronidazole, you should definitely see this one tomorrow. So the way my tutor taught this last year was you want to so GET, get to the metro, or you'll end up at the bar having a couple drinks. So make sure you know that metronidazole is used to treat Giardia, Trichomonas, and Entamoeba histolytica, which I think Dr. Colley talked about that one a lot. And then very high yield, know that with metronidazole, when combined with alcohol, you can get what's known as a disulfiram reaction. And I guess it's actually called a disulfiram-like reaction because disulfiram, it targets aldehyde dehydrogenase. And that's what, it converts acetaldehyde to acetate, I believe. So metronidazole is going to target this enzyme, and then you get a buildup of acetaldehyde, which has toxic effects. And I have, there's a practice question related to this later on in the slides. So if you didn't get that down or you want to see that again, I have a picture of the actual reaction. So we'll get to that. Yeah, so get to the metro. First aid says get GAP. For now, just know the get part, and then your disulfiram-like reaction. Okay, so Primaquine is used to treat these two species of malaria. And the most important thing, two important things to know about Primaquine is the fact that it reaches peak plasma levels in 1 to 2 hours. So if you have someone who is going on a trip on short notice, this would be a good choice because you only need to start it 1 to 2 days before traveling. And then important to know are your drugs that have an adverse effect of drug-induced hemolytic anemia and G6PD deficiency. So do you guys remember what are some other drugs that we've talked about so far that also have this risk? So Primaquine, and then what else? Can you get drug-induced hemolytic anemia in patients with G6PD? Right, sulfur drugs, yeah. Sulfur drugs and nitrofurantoin. Exactly. So keep that in mind for tomorrow. So G6PD deficiency. I believe last year on the exam, she had an image with these bite cells, and she showed you that in one of her lectures. And then if you go back to, I don't remember if I think it was the first session. I also had a practice question on this. So make sure tomorrow you know how G6PD deficiency presents, you know what bite cells look like, and you know what drugs you have a risk of drug-induced hemolytic anemia with. If you can do those things, then the question shouldn't be a problem. Okay, so with chloroquine, so you want to know that chloroquine resistance is very common, so especially when you're talking about P. falciparum. And yeah, so that, and then also the fact that it may exacerbate psoriasis. So with these anti-malarial drugs, I would know, of course, what it's effective against, and then you want to know advantages and disadvantages to using it. So, can the medication be taken at the last minute, or do you have to take it for a long time, et cetera, things like that. And then also any adverse effect. So you want to associate chloroquine with exacerbation of psoriasis. Okay. Okay, so atovaquone proguanil. So this is given in combination. It's good for both last minute travel and shorter trips because you only have to take it for 7 days after you return. Um, I believe it, I don't think she had it on her slide, but I think it treats P. falciparum that's resistant to chloroquine. So somebody can fact check me on that, but I'm pretty sure that's what it's used for. Okay. So mefloquine. So it's an effective single agent for prophylaxis and treatment of multi-drug resistant forms of P. falciparum. Um, so the big thing here is you want to be careful in patients who already have psychiatric history or issues because mefloquine can exacerbate that. Okay. Quinine, the big thing to know here is that it can result in a constellation of symptoms known as cynicism. So, ringing in the ears, headache, nausea, flushing, dizziness, and visual disturbances. Okay. Doxycycline can be used as an anti-malarial, but you want to keep in mind, which doesn't make a lot of sense to me. It seems counterintuitive because if you're going to an area where malaria may be an issue, you know, it could be sunny or it's likely sunny. So you want to avoid using this if the person plans on being outside a lot because it's one of your drugs that has an adverse effect of photosensitivity or phototoxicity. So remember the sun fries. So your tetracyclines, sulfonamides, and fluoroquinolones. Okay, and then nitazoxanide. No, I can't say it. This one. Approved for use in Giardia duodenalis. This is the one that you're going to see most commonly asked in questions. How do you treat prophylactically for P. falciparum if the patient has a history of neuro disorder? Um, my guess would be chloroquine, unless it's a chloroquine resistant area. But I'm not sure if that can be used for prophylaxis. That's something that I would have to look up because I'm not sure, to be totally honest with you. Okay. Primaquine is prophylaxis for all of them? Okay. Yeah, I can look into that when we get done here for sure. Actually, why don't you guys go ahead and answer this? Yeah, go ahead and answer this first question, and I'll see if I can figure that out. So it looks like, according to Google, chloroquine was extensively used for P. falciparum prophylaxis, but I think that's why it's largely resistant now. Okay, yeah, so then Primaquine would be a good choice. It's also saying that methloquine. Yeah, which we know that one. But of course, the neuro disorders are a problem. So yeah, probably Primaquine or chloroquine would be your best options in someone with a psychiatric issue. Yeah, no problem. Okay, so the drug staining bodily fluids red. Yep, you guys got that one. So that's rifampin. Okay. Next question. The same patient is also taking isoniazid as part of combination therapy for treatment of TB. In order to prevent peripheral neuropathy, you should supplement his treatment with which B vitamin? Yep, good job. Pyridoxine, vitamin B6. Next, 6 months later, the same patient returns and you diagnose him with a SLE-like syndrome. Which drug likely caused this adverse effect? Right, isoniazid. So here's your SHIP, or you're eventually going to learn SHIP-E mnemonic. Okay, so here's one from USMLE RX. A 32-year-old immigrant visits the clinic with no previous medical problems, but feeling more tired and ill lately with a decreased appetite and frequent nausea. He's taking one medication that he was instructed to take 9 months after his wife fell ill with a severe cough. He does not take any supplements. He drinks a few beers. Physical exam unremarkable. Abdominal tenderness on the right upper quadrant. Okay, so which of the following is most likely responsible for this patient's symptoms? So what do you think his wife had or has? Right, she has TB. So he's being treated prophylactically for TB. So what is the one agent you can use for prophylactic TB treatment, right? Great, good job, you guys. Okay. So you have a 48-year-old woman who is an immigrant from India, comes in for evaluation because of chronic cough, fatigue, and weight loss. For the past 2 months, she has been producing increasing amounts of non-foul smelling green-yellow sputum and also occasional blood-stained sputum. Denies alcohol and drug use. Past medical history doesn't contribute. She has a fever, pleural effusion, and then she ends up with diminished sensation to light touch, pinprick, and vibration. Which of the following should be administered to minimize adverse symptoms? Right. Yeah, so vitamin B6. Okay. A 32-year-old female presents to the clinic with vaginal itching and a foul-smelling discharge that is worse following her menstrual period. She is sexually active with 2 partners and recently had unprotected sex. Pelvic exam shows erythema of the cervix and a frothy yellow-green discharge. So this right here, this should give it away for you. What are you thinking she has? Trichomonas, right? So what are you going to use to treat trichomonas? Right. Good job. So one way people remember metronidazole is it's for your below the belt infection. So literally stuff that happens below the belt. Okay. You prescribed the patient in the previous question the appropriate medication, so metronidazole, and caution her that this drug causes an adverse reaction to alcohol. She tells you she was planning on going to a party Friday and wants you to explain to her why she shouldn't drink. You tell her that combining this medication with alcohol will lead to an accumulation of acetaldehyde, a toxic metabolite of ethanol, by targeting which enzyme? Right, good. So aldehyde dehydrogenase. And here's this reaction. Okay. So disulfiram targets aldehyde dehydrogenase. So any disulfiram-like reaction is going to act right here. So you have ethanol to acetaldehyde via alcohol dehydrogenase, and then acetaldehyde to acetic acid via aldehyde dehydrogenase. Okay, so what antifungal did she talk about that can also cause a disulfiram-like reaction? Right, you guys got it, the griseofulin. Okay, so it's Monday and your 8 a.m. appointment is a 20-year-old female patient who informs you she's leaving the country this Friday to go to Africa on a mission trip with her church. Her past medical history is positive for G6PD deficiency, psoriasis, and depression. Which anti-malarial prophylaxis will you recommend? Right, you guys got it. Yeah, so make sure with these anti-malarial drugs, you know which adverse effect is associated with each of those. All right, so a 48-year-old male patient in the ED tells you he has a terrible headache and his ears are ringing. He also says he vomited on the way here. You look at his vitals and his temp is 101 degrees Fahrenheit. You ask him what medications he's taking and he says, I'm taking an antimalarial drug because I just got back from a trip overseas, but I can't remember the name of it. Which drug is he likely taking? All right, good job. So he's taking quinine. A 30-year-old female is traveling to an area where the primary malarial species is P. falciparum. What is the most appropriate prophylaxis for this patient? Yep, good job, mefloquine. Okay, so this came out of BRS. A 14-year-old boy returns from a Boy Scout backpack trip with foul-smelling, watery diarrhea. On further questioning, he admits to drinking water from a mountain brook. Stool scent for ova and parasites, confirming Giardia. Okay, so like I told you, Giardia is the one you're most likely to see when being asked about this drug. So which drug was that? Yeah, so the correct answer is A, metronidazole. So Giardia, entamoeba, and trichomonas. So is he not considered a child, I guess? Um, yeah. Were you thinking that this was nitrous oxide? Yeah. Um, about what's considered a child for the exam. She shouldn't give you both options, no, because they didn't hear. I mean, I think they probably were trying to throw you off with B. But yeah, no, I wouldn't worry about that. Yeah, a lot of these questions from USMLE RX and BRS, like they're assuming that you've had like a lot of the second year material. So what you see tomorrow is going to be extremely straightforward. All right. Okay, so get into the antifungals. So amphotericin B, we call it amphoterrible because of all of its bad adverse effects. So keep that in mind. And then the fact that nystatin is used topically to treat candida. Okay, so again, amphotericin with all of these bad adverse effects. Flucidazine, she didn't really have a lot in, I don't think she had anything in red besides the drug name. So if I were to know anything, I would know the mechanism of action and then the fact that you use it in combination with amphotericin B for cryptococcal meningitis. Okay. The most high yield thing from this slide is the fact that ketoconazole has an adverse effect of gynecomastia. So, like, you'll likely be given a question stem, saying your male patient is being treated for something like prostate cancer or Cushing's, and now he presents to the clinic concerned because it looks like he's developing female breasts. So when they ask you what drug he's likely taking, it's going to be ketoconazole. So this is something that is going to come back up a lot. So I would make sure you know this one. I'd be surprised if she doesn't ask about it tomorrow. Okay. And then obviously, anytime you see azole, that's a good way to remember that those are antifungals. So if you have a list of drugs and you see azole after it and the stem has nothing to do with a fungus, it's probably not the right answer. So just keep that in mind. Okay, yeah, so first aid definitely points out the gynecomastia and ketoconazole. Okay. So the echinocandins, make sure you know everything that treats candida and then also aspergillosis. Okay, so what to know here? I would know that anything with NAF in it, so terbinafine, tolnaftate, etc. So terbinafine, the big thing here is if somebody has a nail infection, so onychomycosis, that's referring to a fungal infection of the nails. So if you see that described in a question stem and they want to know how to treat it, you're looking at terbinafine. And one of the reasons this works so well is because it accumulates in the nails. So the drug is going exactly where you want it to target. All right, so griseofulvin, if she asks anything, it's going to be about that disulfiram-like reaction. So keep in mind griseofulvin and then metronidazole. Your antihelmintics, so your benzimdazoles, so albendazole. The big thing she pointed out here is the fact that oral absorption can be increased with a fatty meal. And so when do you want to do that? So if the infection is invasive, you want to give it with a fatty meal because it's going to increase absorption and get to the rest of the body, not just the gut. But if the infection is intestinal, then you want to take it on an empty stomach because you want the drug to target the gut because that is where your infection is at, rather than it being absorbed and distributed. So if you do have an invasive infection, make sure you choose albendazole over mebendazole because mebendazole is less than 10% of it is absorbed orally. Okay. I don't think she'll ask about this because this drug isn't really used in the U.S. Because this isn't a problem. And then also, you have a lot of adverse GI effects that you'll learn about second year. So everyone really kind of shies away from this drug. So I wouldn't worry about this one. I would think about ivermectin though. If you see a question stem describing this Mazzotti-like reaction, then and they say what drug are they likely being prescribed, that's going to be ivermectin. Okay. Yeah, so I would just know what these are used for. So pyrantel pamoate for pinworms, and then praziquantel for trematodes and cestodes. Okay, yeah, and if you get a stem about head lice or scabies, you're looking at permethrin or lindane. Okay, so let's get to the questions. A 12-year-old girl has undergone. Do you know if they still do 3-question per lecture for pharm as well, or is it a free-for-all? Sorry, I just saw you send that to me. Jesse, I just saw you send that to me privately, but in case anyone's wondering, as far as I remember, it's still the 3-question per lecture rule. So yeah, the questions should be evenly distributed. Okay. A 12-year-old girl has undergone a bone marrow transplant for the treatment of acute lymphoblastic leukemia. 5 days later, she develops fever and blood cultures reveal Candida albicans in her blood. Which of the following antifungals would be most appropriate to use immediately? Okay, so yeah, the answer here is E, amphotericin. So remember nystatin. Let's see, what does it say here? Yeah, so nystatin is for oral candidiasis. So she has a systemic infection. I don't think the question will be this difficult tomorrow. I don't think that you'll be given like 2 drugs that treat candida as answer choices. So I wouldn't worry. Yeah, don't worry too much about this. Okay. This question should be a little more straightforward though. A 50-year-old male is being treated for prostate cancer. He presents to the clinic with breast hypertrophy. Which drug is he likely taking? Right, ketoconazole. All right. You have a 6-year-old female patient with diabetes. She removes her socks to show you her toenails and says she's embarrassed by them. Which antifungal should you prescribe her? Right. B, terbinafine. A 40-year-old male is prescribed an antifungal to treat ringworm. After coming home from the pharmacy, he takes his medication and drinks a few beers. The next morning, he experiences nausea, vomiting, dizziness, and headaches. Which antifungal was he likely prescribed? Right. So the answer to this one is C, griseofulvin. And make sure, so I think on our slide it said it's used to treat dermatophytosis. Like, make sure you know that that means ringworm. So like they could show you a picture of someone with ringworm on the exam. So just make sure you know what that word means. Okay. Microscopic exam confirms strongyloid stercoralis is present in a patient's stool. This morning, the patient complained of itching, and you noticed tender swollen lymph nodes on physical exam, for which you prescribed aspirin and an antihistamine. This patient's filarial infection is likely being treated with which drug? Right, so the correct answer is D. And what reaction is this describing? What is the name for it? Right, Mazzotti. Good job. Okay, so I had practice questions with like the other two sessions, but so I tried to come up with some new ones just as a review. So we're kind of like going back to the beginning here. Okay, so a drug has been administered to a small group of healthy individuals to determine the body's effect on the drug. The drug is likely in which phase of clinical trials? Right? Phase 1. Okay. A drug has now entered the phase in clinical trials that studies rare side effects caused over time by new treatment after it has been approved and is on the market. What phase are we in now? Right. Phase 4, because that includes post-marketing surveillance. So that's when you're looking for those rare and idiosyncratic side effects. All right, and then I will post this version just as soon as we're done. So I try to include the slide that the questions cover, like after that question. Okay. 20-year-old female is a pre-med student. She has spring allergies and tells you she's stressed because she falls asleep every time she tries to study for the MCAT after taking the medication you prescribed her in her last visit. She says something must be wrong with her. You look at her chart and notice she's taking loratadine. What do you tell her? Great, good job. Drowsiness is a common side effect of antihistamines. Okay, so know the difference between an allergy and a side effect. Right, you're training a new pharmacy tech who is full of questions. A 25-year-old female brings in her prescription for ibuprofen that was written in January, and the tech, yeah, the tech asks you if her prescription is still valid. So what's the correct answer here? Right, Catherine's got it. So ibuprofen is a non-legend drug, and the script is valid for 1 year. The patient comes in with a fraudulent script for a Schedule II drug. The pharmacy tech brings the prescription to the pharmacist and notices that a vital piece of info is missing. Right, so the correct answer is B, the prescriber DEA number. So don't get tripped up by A. If you know it's a Schedule II drug, you know that it cannot be refilled. So that information would not be necessary. All right, which route of administration results in 100% bioavailability? Right, the IV route. Make sure you remember that. Okay. So you have an acidic drug in an environment where the pKa is greater than the pH. What is the drug's ionization? Right, so it's going to be ionized because you have an acidic drug in an acidic environment. Or I'm sorry, if I said ionized, I meant unionized. Okay, so if you have a basic drug in an environment where the pH is less than the pKa, what is the drug's ionization? Right, so in this case, it's going to be ionized. All right, if you are not a chemistry wizard, which I am definitely not, the only thing you need to do before tomorrow is memorize this chart, and you will get that question right, however she decides to ask it. So as long as you can draw this chart tomorrow for your exam, you will do just fine. So do not stress about that. Okay, and here in words, if you want to review. Okay, so slightly tougher. Aspirin is ingested and is now in an environment where the pH is less than the pKa. How will this affect the clearance of aspirin? Right, you guys got it. So if you think about this equation here, which the only thing you need to know for tomorrow is the clearly Cali multiplies VD, but clearance is also proportional to the rate of elimination of the drug. So if the rate of elimination decreases, that means the clearance is also going to decrease. Okay. The plots shown below represent which type of kinetics? First order or zero order? Right. This is zero order kinetics. So make sure on the exam tomorrow you check out the graph. So if you have a logarithmic graph, zero order kinetics is going to be curved, whereas just in a simple time versus units of drugs, it's going to be straight line because the drug is eliminated in a constant fraction in zero order kinetics. Okay, so 2 examples of zero order kinetics that you need to know. Right, ethanol and aspirin. Okay, and then this I clipped out of the Kaplan lecture notes. So here it's showing you the difference in how the graphs will appear. And then to remember the drugs that follow zero order elimination, this mnemonic P, so phenytoin, ethanol, and aspirin. The only thing you need to know for tomorrow, though, is ethanol and aspirin. Okay. So, and then make sure you know that in zero order elimination, it's a constant amount per time, whereas in first order elimination, you're getting a constant fraction of drug eliminated per time. And then she'll probably give you a question, well, maybe she might give you a question where you have to calculate the half-life by looking at a graph. So make sure you can do that. Okay. This should be on the exam tomorrow. So how many half-lives to steady state? Right, 4 to 5. It was on there last year. So hopefully you get this easy one tomorrow. Okay. So we definitely had questions like this on the exam last year. Okay, so what is the effect of prescribing rifampin to a patient who is already taking clopidogrel? So rifampin is an enzyme inducer, and it induces 2C19, so it activates clopidogrel. So yeah, you guys are correct, an increase in the amount of active drug. So be sure that you can look at a chart like this and then answer your question. You don't need to memorize anything, like she will give you all of the information in a chart. You just need to be able to interpret it. I guess that's the best way to put it. Be able to interpret a chart like this. Okay. Which of the following statements is true when comparing drug A, which is the purple line, to drug B, the green line? Right, so the correct answer here is C. Drug B has a lower EC50, so it is more potent than drug A, would be another way of saying that. Okay, so out of USMLE-Rx, you have a dose response curve, and which of the following can be concluded about drugs A and B? So looking at the blue and the red line. Yep, good job. So the correct answer here is C. Drug B is less effective and more potent than drug A. So make sure you know the difference between potency and efficacy for tomorrow. So if you reach if the Emax is smaller, um, this means that the drug that is less efficacious. But if you have a smaller EC50, so the dose response curve is shifted to the left, then that means the drug is more potent. So if you get that, this should be an easy question tomorrow. Okay, which of the following is an action of a competitive antagonist? Right, so the answer here is C. This one's a little bit tougher. So if you were in that session, I kind of walked through. So this picture here was made by my tutor last year. So if you can understand the difference between a competitive and non-competitive antagonist, then you're going to get this question right tomorrow. So a competitive antagonist, when combined with the drug, it's going to increase the EC50 or decrease the potency, but it can be outcompeted to produce 100% Emax, so the efficacy is going to be the same. So if she shows you a graph tomorrow, you want to look at the change in potency and the change in efficacy when the antagonist is added to the drug in order to determine whether it's competitive or non-competitive. So if you add a non-competitive antagonist to the drug, then your EC50 does not change, but you've lowered the efficacy. So again, if this is something, and then in the question, it talked about shifting the dose response curve to the right. So that's another way of saying that you're going to make something less potent. So that's another way to say the same thing. Or a downshift refers to a decrease in efficacy. Is EC50 and KM the same thing or no? I'll have to double check that. I believe so, but I think when you're talking about like drugs and a dose response curve, they call it the EC50. So I think KM is just a less specific descriptor. Does that make sense? Yeah, yeah, you are right. Same math, different principle, right? Okay, so getting into some antibiotics here. So you have a 14-year-old with cystic fibrosis who has been hospitalized multiple times for pneumonia. brought to the ED with a cough, fever, and shortness of breath. Bronchial alveolar lavage reveals Pseudomonas. Let's see, when no clinical improvement is observed, she gets imipenem, broad spectrum from the carbapenem class, which is the following as a mechanism of action, most likely administered with imipenem to boost its efficacy. So what do you give with imipenem to boost its efficacy? Right, cilastatin. And what happens when you give a cilastatin with imipenem? Right, so Amy is correct. The correct answer is E. So remember, yeah, something with the kidneys. Yeah, so if you know that much, you could get that right here. So inhibition of dehydropeptidase 1 at the proximal tubule of the kidneys. So just remember that mnemonic, the killing is lasting with cilastatin. So if you add cilastatin to imipenem, you're going to get a better effect. And that's because of cilastatin's action on the kidney. Okay. I don't know why that's there. I need to fix that. Okay. So next question. A 40-year-old woman comes to the doctor because she's having multiple watery bowel movements every day with stomach cramps. She's had a cold that won't go away. Right, so yellow white plaques lining the colon. Yeah, the correct here is oral vancomycin. What condition does she have? Right, C. diff, so first line treatment for C. diff is going to be oral vancomycin. Okay. Okay, so same thing here. The white-yellow exudative plaques adherent to colonic mucosa. Sorry, you guys, for some reason I didn't get the answer options in there. So again, oral vancomycin. So make sure you know the mechanism of action of vancomycin. I think that's also something that she hadn't read. All right. Next, a 27-year-old IV drug abuser is admitted for fever and shortness of breath. Multiple blood cultures are drawn, demonstrate Staph aureus that are resistant to methicillin. So basically she has endocarditis. What is the most appropriate antibiotic? So you're treating MRSA. Right, so the correct answer here is going to be D. So she has MRSA, and you're going to treat her with oral or IV vancomycin. Right, IV. And that's something that should show up tomorrow. She said not to worry about knowing routes of administration for most drugs, but she does want you to know when you use IV vancomycin versus oral vancomycin. So make sure you know IV vancomycin for MRSA versus oral vancomycin for C. diff. Okay. All right, next question. A 27-year-old man presents with complaints of painless ulcer on his penis. So based on this description, this first sentence here, what do you think he has? Correct, syphilis. Okay. So what is the treatment of choice for syphilis? Right, penicillin G, or Sorry, guys. I'm not sure what the difference is between benzathine penicillin G and regular penicillin G, but apparently A is the most correct answer. But that's not something, I'll be honest with you, that's not something that we've ever learned though. We were always told that penicillin G was the appropriate treatment for syphilis. So if you know that much penicillin G, you'll be fine if you say that tomorrow. Why not B? Hold on just a second here. Okay, so penicillin B, I'm pretty sure it's usually used in strep and it's administered orally. So in order to treat syphilis, you want an IV route. But yeah, penicillin B for strep. Okay. Yeah, no problem. All right, so 56-year-old woman presents to her primary care physician with a painful cut on her lower leg where she scraped it on a rusty car door. It's now warm and red with purulent exudate. Don't worry about the labs. You don't need that to answer this. So the culture shows gram-positive organisms in clump, susceptible to methicillin. So how are you going to treat her? So make sure you know the difference between methicillin susceptible versus resistant. Yeah, and we have a vote for A, which is correct. So remember your mnemonic, ox, diclox, what is it, NAF, treat staph. Yeah, ox, diclox, meth, NAF are anti-staph. Yeah, so keep that in mind to treat any staphylococcal infection. Okay, so this was an exam question last year. Yeah, it was very similar. Should be a freebie on the exam tomorrow. Yeah, and you guys are all over this one. So beta lactamases, clip the beta lactam ring at position D. Okay. In bacterial meningitis, third generation cephalosporins are common drugs of choice. However, in neonatal meningitis, they would not provide coverage if the infection was due to which of the following organisms? Right, we have a vote for B, and that is the correct answer. So remember your mnemonic that cephalosporins are lame. That is very high yield, so that should show up for you tomorrow if you know that cephalosporins are lame. Okay, which of the following antibiotics covers Pseudomonas? Right, the correct answer here is C. So remember, ceftazidime covers Pseudomonas. Okay. The patient being treated for Pseudomonas. Don't worry about his vitals. Urinalysis reveals muddy brown cast. After 1 week of antibiotic therapy, his urine production drops significantly. Basically, his kidneys are messed up. So which of the following drugs likely caused this patient's condition? So it has to be something that can treat Pseudomonas, number one, and number two, something that's nephrotoxic. Yes. You guys got it? So gentamicin, remember that your aminoglycosides are very nephrotoxic and that they will also cover Pseudomonas. Okay. Cultures are positive for vancomycin-resistant enterococci. Which of the following antibiotics are most appropriate to treat this infection? Right, good job. Linezolid. Okay. 24-year-old woman sees her primary care physician because she has been experiencing burning on urination and increased urinary frequency. She denies fever, chills, or flank pain, but acknowledges having a new sexual partner. A urinalysis is performed, which is positive for leukocyte esterase and nitrates. She's prescribed the first line. So what is the most likely mechanism of action for the first line treatment? Yeah, that's okay. Yeah, this one is really difficult. This is much more difficult than what you're going to see tomorrow. So she had a UTI, and the way that you know that is this positive leukocyte esterase and nitrates. Yeah, but you do need to know the mechanism of action for TMP SMX. Okay, so tough one there. Sorry about that. Okay. This one I think you'll get though. A 27-year-old African American woman is seen in an emergency room with complaints of urinary. Hold on just a second. Complaints of urinary frequency, urgency, and dysuria. Urinary analysis demonstrates bacteria in white blood cells, and she is given TMP SMX. She now returns with sores and blisters around her mouth on the inside of her mouth. Given her history and findings, what should you include in the differential of her current complaint? Right, so the correct answer here is B, Stevens-Johnson syndrome. Okay, so let's back up a second. Okay, so the question here is the first line treatment for a UTI TMP SMX? If it's an uncomplicated UTI, why would it not be cephalosporin? I guess you could, but the first line treatment for UTI is usually TMP SMX. Okay, it's concentrated in the urine and there's no resistance. It's delivered unchanged to the urine. Jennifer, what are you referring to? Oh, nitrofurantoin. Are you asking why it's not that? No. Okay. I thought fosfomycin was first line for UTI. Okay, so don't let this confuse you. When you treat UTIs, there are specific scenarios in which one antibiotic might be like more appropriate than the other. And so that's going to be something that you go into next year. I don't remember what was on her slide for fosfomycin, but TMP-SMX is the one you're going to see most commonly. I will, hold on, let me see if I have the slide after this. Okay. TMP, no, she doesn't talk about it. Okay. At this point, yeah, if she has fosfomycin as first-line treatment for a UTI, then I would go with that right now. Okay, since she's not talking about TMP-SMS in her slides. Okay, so sorry, I hope that, using these USMLE questions doesn't create more confusion. Any question like this, yeah, this is nowhere near as difficult as what you're going to see tomorrow. So don't let it confuse you. It says effective against a gram. Yeah, so fosfomycin. Yeah, Jesse, you're absolutely right. So she's only going to give you one drug that's effective in treating a UTI for tomorrow. So yes, fosfomycin can be used for a UTI, but just know that there are a lot of drugs used for a UTI, and there are specific scenarios which makes using those most appropriate. And I know I kind of got in trouble with this last time because somebody messaged me about one of my questions, and I think they had asked Dr. Weaver, and she's like, we don't get into what things are used for this year. So yeah, I'm not even going to go there because I don't want to create more confusion. So whatever she has on her slide, that's the only thing you need to know right now. Okay. Yeah, no problem. Okay, I think we're here. So you're given IV ciprofloxacin. What is the mechanism of action of this drug? Yeah, and see, here's another example where they're talking about using Cipro and they have a UTI. So there's a lot of things that can treat UTI. So what's the mechanism of action of Cipro? Right, so the correct answer here is E. So it inhibits bacterial topoisomerase 2, which is DNA gyrase. Okay. All right, so we're done. Yeah. So don't even worry about these type of questions. All you need to know tomorrow is whatever is in red on her slides. So these are definitely above where we're at right now. Okay, so should I go back and review some stuff with micro to make sure I have the symptom presentation? Okay, so I had the same concern last semester, and I did very well in this first exam. So a lot of this stuff with symptom presentation, like these questions where you have to make the diagnosis based on the symptoms, they're not going to be that difficult tomorrow. She is probably going to tell you what the diagnosis is and then ask you for the drug. So definitely, if you've forgotten a lot of your micro details, do not stress about that. If you have learned her slides, that should be sufficient enough to do well. Yeah, no problem. Okay, so I'm going to make a few corrections. Yeah, if you've learned her slides, you will be fine. I definitely forgot probably most of micro by the time we reach this exam. So don't panic. All right, so I'm going to make a few corrections, those few misplaced slides I have, and then I will post this version with the answers. And then I'm also going to do a bit of a refresh on UTIs and hopefully I can post something that kind of more clearly answers your guys' questions about that. Um, okay, so does anyone have any other questions? Um, if you're cramming tonight, don't even bother looking at anything that's not in red at this point. If you know everything in red, that's definitely more than sufficient to pass, if not get a good grade. You're very welcome. Oh, no worries. Drop in at any point. Yeah, you're welcome. Good luck, you guys. Happy Easter to you guys. Yeah, so we had our exam moved to Wednesday. Basically to help get more people to pass. Like we had a Combake exam last week and then 2 exams the weekend before. So there was like a ton of information on this last exam. So they were trying to help people out by having it moved to Wednesday. Yeah, so somebody asked me privately, like, why did we have our exam moved to Wednesday? Yeah, so yeah, I'm sorry that couldn't be the case for you guys. Yeah, Matt, I'll add you to the list. All right, good luck, everybody. Yeah, I don't blame you, Andrea. I'll add you to the list. Thank you. Okay, I'll get you.